So our case today is a complex left main PCI post-CABG. It's an 82-year-old male presenting with shortness of breath and a non-STEMI. He's got a previous history of rheumatic mitral stenosis with a mechanical mitral valve replacement in 1992, ischemic heart disease, and at the same time had bypass surgery with a lima to the LAD and a vein graft to the PDA. He had an acute coronary syndrome last year, 2022, treated medically. And at the time, his coronary angiography showed a left main of 50% and included circumflex and both a lima and a vein graft that were patent. He's also known for hypertension, dyslipidemia. He's got left ventricular dysfunction with an ejection fraction of 40 to 45%, moderate tricuspid regurgitation and moderate aortic stenosis and atrial fibrillation. So he presented this time with increasing dyspnea for the past 4 weeks, as well as new onset chest pain with ST elevation in V1 and V2. So he was transferred from an outside hospital to our institution. When he arrived, his ST segments had normalized and his chest pain had improved, but he did have an elevated troponin and he was diagnosed with a non-STEMI. And we repeated his coronary angiography, which we'll show you in a couple of minutes. So just to summarize what the angiography is going to show, we have progression of left main disease with now a lesion of 70 to 80%. It's a very calcified lesion. We have a long first diagonal branch with a 90-degree angulation and a small septal, but the rest of the angiogram is unchanged from 2022.
With the information we have now, what we want to do is to go through the lesion, the left main and the proximal LAD, which are very calcified, to open the segment for the very large diagonal branch. Because the diagonal is a 90 degrees angle, we think we cannot go through. So we'll put the wire in the septal branch, and then use a very small burr, 1.25, 1.5, and use imaging facilities if we need, probably at the end, and then we'll decide for stent and antiplatelet therapy. The left main in the LAD, you can see that there's very tight lesion. There's 50-60% lesion on the left main proximal LAD, but a very tight lesion suivante just before a very large diagonal branch. That's the spider view. You see the 90 degrees angle of the diagonal, and I think there's a very small part of LAD past the diagonal and then a septal branch. And you can see that there's a tight lesion at the septal branch. We don't want to open this tight lesion, but we know that our wire will have to go through. So that's why we use in a hydrophilic wire, we use a BMW 2, and you'll see maybe you can see les prochaines. So we'll look at the lima, which is still good like last year, and which you see the LAD coming up until the very proximal part just after the diagonal. So the rest of the LAD is well perfused with the lima next. So that's the graph on the right, which is okay with small disease, and collateral to the circumflex. So all this, and there's the akinesia is on the inferior wall with the 40 to 45% adjacent fraction. So you see the very tight lesion just before the diagonal branch. You see the tight lesion on the septal branch. And with this angle, we think that with the tight lesion just before the diagonal and the 90 degrees angle, we cannot go in the diagonal with the wire. It would be very difficult. And the rotablator cannot do this 90 degrees angle. So we prefer to go straight in the septal branch, do rotablator, put the stent, if we can, just after the diagonal, and hope that the diagonal will stay open, no disease, 90 degrees angle.
Yeah, just to summarize, I mean, it's a really interesting case. This is a gentleman who comes in with a non-STEMI. He does have moderate valve disease, and the discussion was, no need to really treat the valve disease now and to really focus on the presenting illness, which is this non-STEMI. As Serge very well explained, we want to preserve flow and improve flow to that diagonal branch. And to do so, we're going to treat the left main proximal LAD, but not actually stent into the diagonal, but stent in front of it.
So we push, that's the turnpike, which just cross the very tight lesion and the septal. And that's the BMW, which I will retrieve next, and that's the Rota wire. So we're ready to go through with the Rota Pro. We use the smaller burr, 1.25, We think that we can probably do the job with 1.25, 1.5. If we need 1.75, then we have the 7th French, which will be easier to go through. So you see the burr, which is in the guider. So we're ready to go. And we'll run at 180,000 RPM. Okay, I think we'll start there. We're just in. You can see the guider, it's there. We can go out. So it was, I went through the first part of left main in proximal AD, but not in the distal lesion, which is the tighter lesion. So I'll go with another. What about other technique to go through that calcium? We don't think that the shockwave would be able to go through. We think that really the rotoblader is with the 1.25 is the technology can go through that kind of very calcified, very long lesion. And we couldn't have tried with NC balloon, high pressure balloon, but I think that because of the length of the calcium, it's better to go with that kind of preparation with the atherectomy, a more powerful wire, like maybe a pilot 150 or something like that, which can go through.
So in this case, would you prefer to rewire and re-rotor, or would you prefer to take another wire like our BMW 2, rewire the lesion and see?
Yeah. So and then the discussion is, do the first burr and the halfway of second burr have done the job, and we will be able to go with balloon. But I prefer to go with the BMW wire. So on va prendre le BMW.
Okay, so we've taken out the rotor wire. We're going to take a BMW 2 and rewire the lesion.
It can happen. The burr can be stuck in the lesion. The 1.25 was not stuck. 1.5 was stuck. It means that it's a very tight and calcified lesion.
I'm going to bring the turnpike behind you a bit.
So you see the wire it was difficult for the wire to go through that lesion, but the turnpike is going in.
So what would your strategy be now? Would you put another rotor wire down, or would you?
Yeah, that's the question. I don't think we went through the last lesion, which is very tight. It's not the more calcified, it's the tightest lesion. The more calcification was more in the left main in the proximal AD. Yeah, I think we could try with the rotor wire. We'll use a floppy rotor wire.
So maybe for people who do a lot more lithotripsy, like me, why would you start with rotoblader? When do you prefer to use rotoblader versus shockwave lithotripsy?
Especially because of the profile. When you think it will be difficult to go through with any technology, then it's better to use the rotoblader.
So your first step is to do rotoblader, and then
For me, it's more when you have a resistant lesion that you can use the shockwave.
Okay, so we're going to advance a new rotor wire floppy. Looks like we're heading in that lower branch.
Yeah.
It's not the same branch as before, but that seems to be as far as I can go.
Yeah, je pense que c'est correct.
So our strategy is to go back with another, with the 1.5 burr. Sorry, my wire doesn't seem to want to advance. It's going to keep it straight. Sometimes it gets stuck in the machine. Okay. Now we got it. I have the wire. I don't have the other bit. Yeah, it might be our burr is not the. I may have to change this one out.
Yeah. Okay.
Yeah, I have an issue here on the back.
Yeah.
Okay, so we're going to change the burr.
The position of the wire is very good. So because the burr was stuck in the LED, because we had to go back to go through, it may have damaged the last burr. So we'll go with another one, a 1.5 again.
All right, here we go.
Okay, we're in. Okay, so we went through the distal lesion, but it was again stuck when we pulled back. But I think it did what we want to do. Okay, so we went through for sure. So I think that with the 1.5, we'll go with another wire, maybe with our BMW, another hydrophilic wire, and we'll go with balloon to prepare the left main in the proximal AD for stenting. So I think that the roller there has done the job. We passed through the very tight lesion just before the diagonal branch. So we should be able to go with balloon, NC balloon, or high pressure balloon.
What would you want for your first balloon?
Small balloon.
Okay.
Maybe a 2-0.
0-0. Do little canes? Yeah.
Okay.
Perfect. All right, so we're going to start with our first balloon. It's a 2-0.
So I like the position of the wire. very distal in a large branch. It's in the septal branch. So for sure, even if we use the rollator, we need preparation. And we want to see balloons that are well expanded before going with any stent. There's no way the stent will be better to crack the lesion than the balloon alone. First, you see how it's easy to go with the balloon. I don't want to go too much in the septal branch. Yes, and I will put the balloon just distal to the ostium of the diagonal.
We're on at 14.
The balloon, it's only a 2, but it looks well deployed.
It does. It looks well expanded.
Probably maybe 16.
Sure. 16 atmospheres.
Okay, off.
Off at 20.
So what was the question again? Well, the circ is occluded, completely occluded with collaterals from the right. So it's like it's proximal lady. The left main has no bifurcation for us.
And see, perfect.
So we could have used IVUS at that point to size the proximal lady. Attention, size the proximal lady and the left main. But I think that with balloon opening the artery, we will be able to see if it's 3 or 3.5. And then if our balloon will well expand, stent the lesion and do IVUS at the end to be sure that we have the right size of stent and a well deployed stent. In that kind of very calcified long lesion, going with IVUS first can be difficult, very easy, you see? Perfect. And it's in NSA balloon. So I don't want to inflate a 2.5 balloon in the ostium of a septal branch. Eh? So I just want to put it before, so after the diagonal, but before the septal branch. It shows us that we've got space to put the stent distal to the diagonal.
I'm at 2.5 at 18 atmospheres. The non-compliant 2.5 by 15 balloon.
Okay, off.
18 atmospheres. Opens nicely.
Okay, off. And then the proximal part. Okay, so another option would have been to go now try to go in the diagonal branch. Mm-hmm. There's probably more work to do in the mid part, in the proximal lady.
Yeah, I think so.
So we'll inflate the balloon in that instance, and we'll see what's the effect.
Especially to see I think the expansion of the balloon in this view is nice. Then we'll know if it's being constrained by that lower calcium.
So we're following our initial plan. Complex case, you always have to think during your case to change your mind. But we're stick with rollator 1.2, 25, 1.5, and then non-compliant balloon to prepare the left main in the proximal lady. At that point, we could probably go with shockwave if we have problem, because it will go through the proximal lady. So it's a combination of different technology to really well prepare the lesion.
Yeah, and I think that's the most important point. Like before you put a stent, really make sure that you've well prepared the lesion, because if you haven't, your stent will not expand.
Here, okay, on
at 16, 18.
Okay, at that point, the distal lesion looks to be well cracked, but we'll look at the proximal lady lesion.
Off.
So I really think that the rollator,
18.
It's better to go when it's a small lumen, very calcified. So for the calcium that is just behind the lumen, it's better to use a rollator. But for calcium that are more in depth, it's better to use, I think, the shockwave.
So here, do you have a sense of what size stent you would use, or?
For the left main, it's probably 3.5-4.
Exactly.
The proximality would be 3.2.
Do you want another balloon, or you want to head to the stent?
I will look at the result.
Okay.
Sneak. I would not go with a stent right away for sure.
No, I still think there's work left there.
Yeah.
I would take a 3.5 balloon.
3.5 and see. So now you look at the LAD just before the diagonal. Looks large. It looks almost 3.2, and the flow in the diagonal is still very, very good. And you see how the diagonal is free of disease. It's amazing.
It is. It actually looks a little bit bigger to me.
Yeah.
So let's just say, sort of thinking ahead, if we're going to put this balloon in, we see the lesion is somewhat changed, but not 100% change. Is that, at what point would you say maybe we should do shockwave before we put a,
Okay, so we can go distal just before the diagonal here. Okay.
All right, on 3.5 by 15 non-compliant balloon at 16 atmospheres.
Well deployed.
Expands, yeah, very nicely.
And
Off.
And the real test is here.
Exactly. I'm going to back her up.
Un petit test juste pour voir si on...
Advance this a bit, yeah. Okay, on.
Okay. Look to be sure that there's no dissection after balloon that rupture. You can have... So I would go with the shockwave.
Right.
What do you think?
Yeah, I agree. 3.5 or 3?
3.5 maybe.
Okay, so we'll take a 3.5 shockwave.
So we're already thinking of our stand. If we use a 3.5, it can be inflate at higher pressure in the left main and the proximal LED to get a diameter which will be near 4. Distal, or I would say LED just proximal to the diagonal, will be more 3.2. I think we can estimate, but the IVUS at the end will help us to make the right decision.
So we have a 3.5 by 12 shockwave lithotripsy balloon.
So it's not unusual to use 2 technology. You need to use the one that you start with for the better thing she's doing. So calcified lesion, long lesion, very small. Shockwave will finish the job and go more deep to really have crack the lesion.
Okay, we're just going to connect up.
So the preparation of the shockwave is not so difficult. So you've got a couple of shots you can use. So, okay, so we'll see how it traveled through that calcium. So I would say easy without good support. It went through. So it means that our lumen is well open. It's only that there's 2 calcified. So maybe, yeah.
I think you're good. Okay.
Okay, so 8 or 10 is enough for the inflation of the balloon. You want to be well opposed.
Okay, I'm at 10.
And you see the waist.
All right, I'm pushing.
Yeah.
Okay, so we've got 10 pulses, and now we're going to take a little break. The balloon will come down. It looks much better expanded. Didn't perforate.
Push a little
yeah,
bit.
Exactly. Just get the tail end of that other one.
What do you think? Do you want to look? I can keep the shockwave here.
Let's do that. Let's do Cine and see what it looks like.
Okay, Cine. Well,
maybe a little more work to do.
Yeah. I think that we see the dissection, eh? So
Yeah.
it means that we cracked the lesion for sure.
Yeah.
Maybe in the upper part.
You want to just stent it?
I don't know, because I'm sure that the left main proximal AD are okay. We see the dissection. It's
certainly well expanded, huh?
Okay, so we'll go with our stent.
Okay, so we're going to bring the shockwave balloon back. We're going to keep that because if our stent, for whatever reason, fails to pass, I don't see why it would. But
3.5.
3.5, we're going to.
Or
3.5, we can blow up to bigger if need be.
Yeah, usually I use balloon to measure. Maybe not the shockwave balloon, because I really want to be on the ostium of the left main, but not too far past the diagonal. So it's probably very important to measure the exact length.
Can we measure it on QCA just to give us an idea?
So we'll put the 2 centimeters balloon in, and if it's 2 times, for sure, a 38 will be needed. If it's a little less than that, we use a 33, 32. We'll use the 15. We use what we have on the table.
Okay, so we're going to use a 2015. We're going to see who's faster, us or our QCA.
Yeah, we'll have the QCA also. So, and then at that point, you can also do IVUS or OCT. And then you will have very precise measurement of length and diameter. So I will go spider view to put my balloon exactly where I want distally, and then but it's probably more than that. It's more proximal, I would say. Okay.
So that's way longer than 40.
Yeah. Okay, we'll film that.
15. Okay. It's going to be 40 almost.
So 38 is the longest balloon. We also have 48, but 48 is too long.
Yeah.
And we'll have to prepare the IVUS for the next.
So we have a 3.538 stent.
You see that we didn't ask for a specific company.
No.
We think that if you prepare well your lesion and your artery, in 2023, there's a lot of stent that can go through. Okay, so
Okay.
I think we need to go in the other room. So it was a pleasure to be with you this afternoon.